Hey everyone, Maria here, and I'm joined virtually by Deborah and, of course, Kristie Knickerbocker. Say hello, Kristie.
Hello, Maria. So
Yes,
excited.
we're so excited to have you here too. Deb's here with us chatting. Got a three-way
I'm
Zoom
here,
going.
yes. Usually I'm the only one who gets to hang out with Kristie, so
I,
I'm happy that Maria's here.
I got a
And
little jealous. I was like, "You're always talking with Kristie. What about me?"
So we made it happen. And I'm drinking the S Pellegrino. I guess that's how you say it. It's blood orange. It's a flavored mineral water. I don't know. It's very effervescent, very bubbly. And then eating oranges. I don't know how I could be any more orange unless I got a spray tan. I don't know.
Well, good thing you didn't go
Got
that
a
far.
spray tan.
Very good thing.
Yeah. I think
What do
you're
you
at
drink?
capacity for orange.
What are you drinking, Deb?
I have kombucha. It's the raspberry flavor and some pears. I'm not drinking alcohol right now. We talked off air about this a bit. I don't feel much different, or I don't think I look different either. And Kristie, you said that you experienced the same.
Yeah, I did this last year. I think I went like 40 days with no alcohol. I just didn't feel like drinking it anymore. And I don't know. I didn't feel much different. So,
I
Yeah,
did
I kind of feel the same.
the whole month of March, actually.
oh yeah.
And did you feel different?
Yes, because when I started to drink, I was like, whoa, it's too much for me. Like after 2 glasses of wine, I was done. That was it.
Really?
Headaches. Yeah,
Oh, so now you spend less on alcohol,
I do spend less on alcohol. Well, this
but
That's
wine,
good.
maybe more on Tylenol.
yes. This wine is sponsored. This is the last half of a glass right now. I couldn't finish it yesterday. I did an interview yesterday. So this is a rosé wine, and definitely drink this wine very smooth. So I'm the only one drinking alcohol right now. So I'm gonna have a party by myself.
Well, good thing because this is SLP's wine and cheese, so someone should be drinking.
Someone, yes.
No,
And I
Kristie's
had
still in her office, so she
I
probably
am.
has a bottle in her drawer.
Don't tell anybody.
Mm.
I got to replace it every once in a while because
Yeah.
then it gets consumed.
What would be your poison if that said?
Oh man, if I had something here, it would probably be whiskey. I just can't not drink whiskey.
Mm-hmm.
I don't know if that's just because I'm Texan, but it's funny because before I met my husband, I didn't drink whiskey. I thought it was gross.
Right.
So I don't know how that
Well, I
happens.
mean, if you're gonna have a bottle of something in your office, it should be whiskey. That's like the coolest thing to pull out of a drawer. If you pull out vodka, people will be like, "Are you okay?" Like,
Yeah,
like
whiskey's more
Christy is like,
acceptable.
"Oh, she's cool. She takes breaks."
Yeah. Or bourbon. What about bourbon? That's like similar to
Right.
whiskey, right?
Yeah,
Mhm.
I don't really know the difference between the two. Like, I really drink Jack Daniels pretty frequently, so I don't know if that's bourbon or
I think
whiskey. I
something
think
has
it's
to do
sour
with
mash whiskey.
Kentucky. One of them is only, I don't know.
We've looked
One of
this up
them's only made.
before. Remember,
Yeah.
shout out, throwback to one of our episodes when we had Katie, the OT, because she only drinks whiskey
Yeah.
as well.
Something about Kentucky. Yeah, so Christy's here today and she's going to talk to us all about working with individuals who are transgender or going through the process. And we're going to talk a bit about feminizing the voice. Is that right?
Well, that's a common term, and we're going to talk about kind of the evolution of our verbiage and our nomenclature, the
Okay.
words that we use and what we were using, and kind of how it's morphed, even since I've been in grad school. So I wouldn't say it's wrong necessarily to say that because people recognize that term, but it kind of went from transgender voice therapy, voice feminization, voice masculinization to gender spectrum voice therapy. And
Okay.
that was, I believe, just because Leah Halou, who has done a lot of grouping of speech pathologists who treat this population, also speech pathologists who identify as this population who also treat this population, which is even more super.
Oh, wow. Yeah.
But she created this nice Facebook group called Gender Spectrum Voice and communication. And there was a voting. We voted for what name we thought encompassed everything. And then so I started calling it gender spectrum voice, because what it moved from when I was in grad school, where I was learning and kind of saying, well, here's how to be the most feminine version of yourself. The more I met these people and I started providing services, it was like, well, let me just teach you, and listening to Leah talk to, let me just teach you how to navigate this spectrum of, because I, as a cisgender woman, which means I identify as the gender I was given at birth. So gendered female at birth, and I identify as female, cis female. And as that person, I function on a spectrum. If I am with my gal pals and we're out at a bar or something, I'm super talkative and I laugh at everything and I'm very obnoxious. And then if I'm watching the game with my husband and his friends, I may be trying to act more tough and maybe lower my pitch a little bit. And body language goes with that too, and nonverbals. But we all function kind of on a spectrum of voice. And now it's come where we're really calling it gender affirmation voice therapy. Because whether you're a trans man or a trans woman, maybe you want to sound a certain way, but our goal should not be to feminize the voice of a trans woman. It should be to give her the tools to find her own voice that she feels like represents her identity and herself in our world. She may need to use it differently depending on who she's around. But that's kind of what we end up doing with our services.
Right. Well, that makes complete sense. And I love that you broke that down for us. So what would the evaluation period sort of look like with a new client?
Yeah, so we go through kind of motivational interviewing similar to what you would do with any other voice client. This includes information about what they may have been doing to change their voice already. Sometimes people come to my clinic and they've been doing YouTube videos. Maybe they've been messing around with some apps and saying, oh, my average fundamental frequency is 200, but I still feel like I sound very masculine. I keep getting misgendered. What's going on? So I want to know their experience with their own voice. If they've had a history of voice therapy in the past, I want to know other professionals that they're seeing. So are they in therapy? Are they in counseling? What kind of medications are they on? Are they taking hormones? If it's a trans man, has he started testosterone? Testosterone is going to have a huge impact on lowering the fundamental frequency of the voice. But there is a paper, and I'm pulling this off the top of my head. Sorry, everyone who's listening, but I know it's Aaron Ziegler. Oh, look, it's it may be voice masculinization, or it may be just transgender voice therapy. But it's about testosterone not doing the complete job. When you interview these patients and say, do you feel like your voice is representative of you? If they just had testosterone, they're not all saying that that's taken care of at all. So they may need some sessions of voice therapy. We think, oh, if you're a trans woman, you're going to need voice therapy, but trans men may not need it because they take testosterone, you're good to go. Right. Not always. And that paper was really landmark in discovering that and providing us with that knowledge. Aaron Ziegler. Yeah, Ziegler. Oh, you did? What's the title?
It's called, we're going to put it in the show notes for everyone listening also, but Effectiveness of Testosterone Therapy for Masculinizing Voice in Transgender Patients, a meta-analytic review. I feel so smart just like saying that title.
You sound smart.
I do? Well, I'm just reading. Luckily, I could read.
It's the rosé. No, it's not. It's you.
It could be.
Saying the background, testosterone therapy is the predominant treatment for voice masculinization in transgender patients. Although lowering of voice fundamental frequency occurs with testosterone therapy, evidence suggests voice and gender identity may not fully align. So what you were just saying, how the testosterone treatment alone will not change their voice maybe as much as they would like to.
Right.
So then they have the results they found that not all transgender patients using testosterone therapy to masculinize voice should expect their fundamental frequency to be lower after 1 year. And they talk about voice problems could be possibly affecting their results, and they're saying a voice evaluation should occur prior to initiating testosterone therapy and involve counseling on expectations for voice, which you also just mentioned too, to find out if they are how far in the treatment of the testosterone they are, or if they even started. As according to this research, they're saying to start the voice therapy first before the testosterone therapy.
Yeah, I think an examination, just to know, this is the great segue, because should we visualize? Should we do video stroboscopy to determine anything else going on in the larynx before we start? So a long time ago, I had a conversation with Richard Adler, and this was years ago, and we were talking about because in our scope, it's like, well, don't treat voice disorders unless you visualize the larynx. Well, do we really consider transgender voice therapy a voice? It is. Hi.
Mike. Yes,
Mike. That's so
and he walks away. He just
all I need is a Frankie Wrinkles. Where's Frankie? That's who I really need.
He's been over here just hitting my leg. I don't know where he just went.
He left.
I need him in my
dog
life.
acts like I don't feed him anything.
That's how they all do.
Yeah.
It's because Dad spoiled him with treats. No judgment, but you admitted it to yourself.
I thought I was training him. I don't know.
Not so much.
But yes, so interrupted your story.
No, it's good. The video stroboscopy. So we decided, well, do we really consider it a disorder, right? Mm-hmm. And I don't really consider disorder. However, we're doing a lot of stretching to increase the pitch of the vocal cords. So we're making them longer. So we may be finding some slightly uncomfortable positions,
right,
for these people. And so I think you're giving them exercise too. So we're saying you may not have been using your voice a lot. Boom, here's a bunch of voice work to do daily. I think there is an argument for a baseline strobe before you begin the therapy. So, the thought is too then, well, do you really need to have them go see an ENT before that? If you have video stroboscopy, can you complete it? Do you need a doctor to sign off on that? So I think up to your discretion. You're seeing anything on strobe that looks odd, I'd send them. Or if they decline the strobe, going ahead and paying really close attention to anything that's different. Are they experiencing pain or hoarseness or any voice quality change that's different from baseline? So I think that if you're at least taking acoustic measures beforehand, you're helping, because it's like, well, here's sound like before. Ooh, man, we're 4 weeks in, you're really hoarse. What can we do? Do we need an instrumental?
Right.
So I think those are questions you need to have with your patient. And
I would think objective measurements would be important, though, just like with any client, So I don't know. I'm a fan of that, I guess you would say. I would like, because
just to demonstrate progress.
As well, definitely establish the baseline. I've actually had one transgender patient one time. She came and that was it. She left, and I was like, "Why?" But I think because insurance wouldn't cover, and she didn't want to pay out of pocket. And I didn't blame her.
That's a really tough situation, and
yes,
fortunately, well, insurance and then travel is a barrier that's been identified as well. So the fortunate part about barriers, they're starting to come down, at least. Is that with this whole virtual baptism we're all in, I've been slammed with gender spectrum patients. Like I've gone from seeing maybe 2 or 3 a week to 7 to 8 a week.
Nice.
Wow,
consistently on caseload. So
are you licensed in any other state?
So I was licensed in Oklahoma, but I let it lapse. Mm-hmm. And there are some states that have reciprocity with Texas, like Iowa right now has done a blanket statement where wherever you are, you can see patients in Iowa as long as you have a current state license. And I think there's probably other states that are doing that too, but ASHA has a pretty good list of that running. So.
Oh,
nice.
Yeah.
I didn't know.
Texas is big anyway, so you would have a lot of people. You're just.
I guess. Yes, Texas is big. But yeah, that's, I mean, a thorough case history, doing acoustics, aerodynamics, video stroboscopy, same thing you would do similar to a regular voice like disorder patient has complaints of that. Things you also want to consider real quick is just perceptual evaluation. Chalet and Davies. There's the transsexual voice questionnaire. But the drawback is it's only male to female. There isn't one for female to male. And that really isn't terminology that we use anymore either. So kind of dated terms on that form anyway. So I always tell people, I'm like, I know this says transsexual voice questionnaire on it, but it was made in this year. So that, the questions are what are important, how you're feeling about your voice. It's like the VHI, but it has questions specific to gender on it.
Uh-huh. And do you advise them to have a voice role model, like someone who they hope to sound similar to, or do you think that gives like unrealistic expectations?
I think that's actually a conversation. Yeah, you do have to have that conversation, and that's part of a first assignment for most patients. I say go home, and usually they have somebody in mind, but go home and listen to trans females or cis females that you really like their sound quality, so I can get a listen to kind of the tone, the timbre of the voice, an accent that they might have, but then also it helps me figure out how we might be playing to shape the resonant cavity. Where are we really trying to make it where the voice is really forward and small like this? Are we trying to kind of move things where it's a little more tough? Are we changing it where it's kind of like that? Is it a very valley girl voice? Are you changing pitch very frequently like this? Is it more kind of laid back and doing things where you're only moving up so far in pitch? Tongue placement's a really huge thing, because if you have a pitch that's in range and you're doing that in therapy, it's not the only thing you need to be focusing on. You need to be focusing on where your tongue is and how constricted your throat might need to be to make that oral space small, where you're messing with the sound signal, the formants that make up that sound signal. So you're not just working on the FO, the fundamental frequency or the pitch.
Right.
But it's like this, the reason I can do, hey, how are you doing? Hey, how are you doing? And it's the same pitches, but I sound like a completely different person doing those.
Right.
But I'm only changing the tongue position, not the vocal cord length. So we teach them how to do that. And you talk about therapy. We're really kind of starting on principles. It's helpful to begin with resonant voice therapy. I use Kitty Bertolini Abbott's Lisak Madsen resonant voice therapy protocol a lot of times to kind of start patients off, so they can start to recognize, what is resonance? That's a really weird word. How do I manipulate that? How do I work with that?
Right.
So that's where you start first, with resonance.
Yeah.
For us, I've had voice patients before, but not as, it's like your expertise. So you would start, let's say, with resonance, and then do you have them like hooked up to something to like see, so when they like, say that target phrase, like they could see it visually, like on acoustic measures, like how does their voice sound? Or is it all just like with their ears? Like,
we use yeah, that's a great question. We use a combination of both. So we use software on computer so that we can look at the formants and look at the spectrogram view and compare. A really easy one to start with and look at is the vowel E, because when you move E, if you isolate that pitch, prolong it, and just move the tongue, the root of the tongue up and down, you can see where those formants change. And you're aiming for that higher formant, so that you're able to sound more perceptually feminine where everything's being made at the front of the mouth.
And then you have a visual feedback.
So I like to use an app. There's a couple apps on the phone, but there's real-time ones that you can actually visualize pitch as well. So then they can start seeing, oh, hey, I'm good at and bottoming out no lower than C3, which is the C below middle C. And then they can start learning what it feels like to flip into falsetto and get comfortable with doing that. So
your background in music theory has really benefited this type of therapy. Would you agree? Or
I would definitely agree. I don't think you couldn't provide the therapy, because I oftentimes wonder how effective I am at therapy for trans men, because I can't really go very low physically in pitch to like demonstrate. So I do think that it gives a little bit of an advantage because you have a knowledge of pitch, but you can be an effective voice clinician and not have music background too, I think.
When I was going over the vocal function exercises, I'm like, I don't know what F is. Like, I don't play any instruments. I don't sing. I dance. That's about it. So I like just went on YouTube and just try to match and I just typed in like F note and I was just like, E no, like the no. So I'm like, all right, let's try to figure this out together. What does F sound like? So YouTube, check it out.
You were completely resourceful. So, and that's the best thing about technology is like, there you go. You don't have to have that music background, sit in front of a keyboard or a piano to do what you need to do.
Right. But it would be a helpful like tool in your arsenal.
For sure.
Yeah. For sure.
So then, can you tell us maybe 2 or 3 sort of therapy techniques that you would utilize with your trans spectrum? Can you say it again? Gender spectrum.
Yeah, gender spectrum voice patients. Yeah, or like gender affirmation voice therapy. I like to have them on, like Maria was saying, the vocal function exercises from Joe Stemple. So we do have them start a regimen of those so that they're able to start figuring out what it feels like to transition pitches from low to high like that. And so we put them on a regimen of that.
Right. It's like choir.
It is a lot like choir. And we do a combination of kind of resonant voice therapy. And then we move to playing around with certain words. So if we're getting really good success with the resonance change on that E sound, we'll move to words that begin with that phoneme. Even, eel, eeny, meeny. And then you can start doing a lot of negative practice where eeny, where we have them change the tongue and feel that spectrum of movement so that they can isolate just that. A lot of times
like
it's
a
hard.
Minimal pair, but you're increasing awareness of that sound by contrasting it.
Most definitely.
Yeah.
Or like core words. If you want to teach stop, you can teach go too. If you're going to teach yes, you're going to teach no too. You want to teach two opposites.
And you probably end up working on core words because you're like, well, these are the more frequently used words in this language, so might as well start there.
Yeah. And then we move to, a lot of times, and you should, let the patient take the reins on it, I did a session today where it was like we could have advanced more in resonance, but she was very interested in learning about vocal anatomy, learning about written communication, what's perceptually more masculine in a text message or an email, what's perception more feminine in that, because unless you're including your pronouns in your email signature, I don't know how we can assume anymore that someone is a certain gender, unless you're reading the email and the nuances that you're picking up from reading that, you're gendering because of how that email sounds. We also talk a little bit about nonverbals, so gestures, facial expressions, head tilt, position of the hips, position, like how you're walking, the gait. These are things that I think improve communication in having your patient be gendered correctly so that they know what they can try and see if that fits for them.
Right. And it's their nonverbal communication. So you're just working on total communication.
Most definitely. Yeah.
Speech.
It's a large umbrella. So
speech and language. So that's great.
Yeah.
SLP, right?
Yeah. Wow, super informative. I bet that these people are a pleasure to work with because they're coming to you voluntarily. I mean, most of the people I see, they're there because their teacher or their parents told them they had to. But you're seeing people who are like, I actively want to make this change, and they're probably super interested and motivated. So I bet that is pretty rewarding.
The most beautiful thing is to have patients come back months later, years later, and send me videos or YouTubes of them doing a presentation or kind of sharing stories about how they got gendered correctly all night long on their shift, or they got gendered correctly by all of their new hires. And it's empowering, I think, to know that you made a difference in helping people navigate the world as it is. And like, I think we can all agree that in a perfect world, everyone would be accepting of everybody else. But the truth is that our current cultural climate, there's still a lot of people who either don't understand, aren't willing to understand, or who actually actively hate people who are transgender. So it's like you think about the things that you don't even think about communication. You walk into the grocery store, you talk to the clerk as you're checking out, and you leave. You go in the gas station to pay for gas and you leave. Those small moments are excruciating at times, from what my patients have told me, where they're just wanting to be gendered correctly, and it's nerve-wracking to go in and do something as simple as pay for your gas. Or buy a Coke.
And to have that idea lingering on your brain hours after that, like, small job had already finished. I couldn't imagine that. So, like, also, I mean, I can't compare it to, I could never understand the struggle, but like, how often do you build something up in your head? You're like, oh, I really don't want to do this because of X, Y, and Z. And I can imagine that many transgender individuals are like, oh, well, when I go to the gas station, it's going to be a whole big ordeal. So you're already like not looking forward to it happening. Then something happens and then it lingers on your brain after. Like, I can imagine that's just like super challenging. And it's important that for their own well-being, and that they are able to have people like you who can help them and who understand and who treat them without judgment.
That's really kind of you to say that. And it's just, you're listening. I learn from patients. I learn from them all the time. And I'm a very different clinician than I was in grad school. It's just because I've listened, and I don't know. They're wonderful, wonderful people. It's like you meet these people, and I don't know. I love all my patients, and to varying degrees and stuff. And I feel a special connection to that population in my heart. So
then I'm wondering, on that note, do you have any sort of quote that you can leave us with? I don't know if I sprung this on you again. Do I ever tell you to get a quote?
No, you always do this.
I mean, I'm going to buy Kristie sometime. She's stretching right now. I did like how you were saying that, like, you really listen to them. And I think that's important as a person, not even just a professional or as an SLP, to just listen to other people. And like, I'm so glad that you were able to come on the show and talk about this topic, because Deb and I really don't know much about this topic. Really, right, Deb? We don't really know.
No, I have friends who are transgender. Nobody's ever come and asked me any questions about voice, so I'm not sure if that's something. Also, though, now that I think about it, I don't know if this impacts anything. A lot of the people that I know, they like work in entertainment in some capacity, so they probably have like a vocal background too.
Yeah.
Well, specifically.
So I'm wondering, I don't know. No one's asking me about it. It's all friends. It's not like clients.
Yeah.
In terms of like, gender spectrum voice or gender affirmation voice, you really like gave us some really good tips. And like, so if an SLP is listening to this and maybe this is something, a part of the field that they want to branch out to. So I thank you for that great information.
I think a quote would just be, you need to listen to the voices of others, because if I'm sitting here saying, here's how I think they feel based on my clinical experience, I'm not a transgender individual. You need to listen to those who are transgender. And I think the most valuable thing in our field is that you actually have these SLPs who are transgender, or they are non-binary, they're gender fluid. We can all benefit from listening to their experiences and listening to how they approach life, so that we're able to listen to our patients better. So I think listening.
Yes. I like
Yeah,
that.
it's important to listen.
It really is. And it might be hard sometimes to listen. You got to fight that impulse to cut them off or,
Mm,
insert your opinion. And it's just active listening. Just nod your head
bingo.
and smile and think about what they're saying and not think about what you're going to say to respond to them.
Next.
Just let that
Exactly.
settle in. But so this
Yeah.
has been, I think, a great interview of SLP of with Kristie Knickerbocker. Thank you so much for all your information. A lot of the stuff that we talked about will be in the show notes. So check out the show notes, and just in case they don't know, in case I missed one of the links or something, where can they find you, Kristie?
I am everywhere. I'm at
Everywhere.
tempovoicecenter.com. That's my clinic. That's my online store. I've got an active Instagram, KRISTIE_voice.
His boom cards.
Oh, you
I have
know
some
it, girl.
cards.
Boom cards out the booty. And
Yeah.
then most recently, I've splashed into the TikTok scene. So I
Oh,
don't know.
yes, I have. Yeah, very nice.
That's a current experiment. Some funny ones there. I creeped for a long time, and now I'm.
Yeah. No, I've been impressed with you.
Oh,
Because
that's great.
I think as soon as COVID happened, everyone TikTok kind of increased. So I started watching it around that time.
Yeah.
And then I would think like, oh, I can try this, but you actually went for it. So that was good. Well
Debatable
done.
on
You
the
did
success
a lot
there,
of
but
the challenges.
it was fun, and some of them are funny. They make me laugh, and that's what's important, right?
Yes.
Like I make myself
Yes.
laugh. Yes,
They're
yes,
great. They
indeed.
make me laugh too.
Y'all
All right.
are
Well, thank you
wonderful.
so much. Always a pleasure talking with
Thank
you.
you. Bye, Maria. Bye, Deb.
Bye.